Assalamu alaikum. Dr. Arshad Namool here. In this video, we will discuss the dengue, that how we are going to diagnose the dengue and we are going to manage the dengue case. The important point in this video will be the management of dengue, that how we are going to manage the dengue, what kids needs admission, and how we are going to give them the fluids. So a brief review of the dengue. That dengue is a fever is caused by viral illness, and the virus infects through the mosquito. And there are four types of dengue. There are four dengue serotypes. These are divided as a DV1, DV2, DV3, DV4, and these may have further subgroups. So how dengue spreads? Basically, it is spreads by the mosquito, and species are Aedes aegypti and Aedes albopictus. The mosquito first bites a diseased person, from where it picks the virus, and then bites a healthy person where it causes disease. The pathogenesis of dengue hemorrhagic fever is that usually it after first infection it does not cause a harm, but when the second infection occurs, the cross-reacting antibodies, cross-reacting T cells to the first serotype will cause activation of the immune system, and that will lead to some immune response, and that leads to the damage that is caused with dengue hemorrhagic fever. This picture is also showing that cross-reactive T cells react with the dengue virus of subsequent infection. So first you get infection. As a response to that infection, you get some antibody response, T cell response, and on second infection, these cross-reacting T cells will react with that second serotype of dengue virus, and then they will activate the immune response, and these immune response will contribute to the dengue hemorrhagic fever. So the cytokine are secreted from the affected macrophages and endothelial cells, and they exaggerate the cytokine response, and then these cytokines finally act on the endothelium of the blood vessels, and then lead to endothelial dysfunction and the fluid leak and all the manifestation of dengue that you see. Dengue has multiple manifestation. One of that is thrombocytopenia. So this picture is showing that why thrombocytopenia is seen in the dengue. So there are multiple levels where thrombocytopenia can occur due to dengue. It may be due to the low production of platelet. That may be due to increased consumption, because there is some element of DIC in the dengue, and direct interference of platelets with the virus, as the virus directly kills the platelets, and there is also increased destruction of the platelet by activated macrophages. So see the different mechanism through which we get low platelet count in the dengue. Bleeding is also seen in dengue. The reason of bleeding again are multiple, starting from thrombocytopenia. As previously we've seen that there is low platelet count, as well as activation of coagulation system due to endothelial dysfunction, DIC, that is disseminated intravascular coagulation, and perfusion of GIT, because there is a hypoperfusion state. Perfusion of GIT is low. GIT endothelium and GIT structures are at risk of bleeding. And also drugs are being used, although not recommended, but being given in the form of steroids or NSAIDs, that also increases the risk of bleeding in dengue patient. Now, organ involvement is also seen in dengue. How they are involved? First is the direct involvement. Virus also infects the organs and causes their damage, like infection of hepatocyte, like infection of brain by the virus, and causes damage to hepatocyte to brain. Second is circulatory failure. Dengue leads to fluid shift from blood vessel to extravascular fluid. There is hypoperfusion state, and hypoperfusion affects all the organs of body. Third is the drugs. Most commonly drug uses for the improvement of fever and the pain is the paracetamol, and paracetamol, if taken in overdosage, has its own side effect, mainly affecting the hepatocytes. Like other viruses, many organ involvement has been reported, like myositis, pancreatitis, myocarditis, although rare, but these can also involve, and can have Stevens-Johnson syndrome, and features may vary from 1 year to another, and one epidemic to another epidemic. So these are not constant features. These can present, cannot present. And also GB syndrome, that is Guillain-Barré syndrome, also seen. So patients with dengue often have the hypoalbuminemia. Reason what? You go for the labs of dengue, you usually do CBC, and also we do the albumin, cholesterol, ultrasound abdomen. So logic of all of these will be explained here, and LFT is also being done. So albumin patient get hypoalbuminemia. The reason being is that albumin and other smaller plasma protein leak from blood vessel, because there is a blood vessels there's leaky blood vessel in dengue because of cytokine response, and albumin and other smaller proteins leak out of blood vessels, so albumin gets low in the dengue. Liver involvement in the acute dengue infection is frequently observed and sometimes leads to acute liver failure with fatal outcomes. Many factors are thought to contribute to liver dysfunction, including hypoxic liver injury due to decreased perfusion, direct damage by the virus, and third is immune-mediated injury. So hypoperfusion, viral injury, and immune-mediated injury. These three factors causes the derangement of LFTs that are seen in the dengue. So clinical features of dengue that you should, on the basis of which you should suspect the dengue fever, is that fever should be more than 2 and less than 10 days. After the 10 days of duration, it's less likely to go in that fever. And presence of fever is the must. Without fever, you can't label someone as a dengue fever, unless patient is in the state of leak, where patient can have the settling of fever along with the aggravation of the dengue symptom in the form of fluid leak. So fever is essential criteria, and fever should be less than 10 days, because after 10 days dengue fever subsides itself. Its maximum duration is 10 days. Headache, retroorbital pain, myalgia, severe myalgias are seen in this dengue, arthralgia, severe backache, bone pains, rash on the body, bleeding manifestation in the form of epistaxis, hematemesis, bloody stool, menorrhagia, hemoptysis, and abdominal pain is also seen, and decreased urinary output despite adequate fluid intake, and irritability in infants. You can't other manifestation like headache, retroorbital pain, myalgias, you will only see the irritability in infants. They will not be feeding, they will be fussy infants. So one common clinical test that frequently asked is the tourniquet test, that how you are going to perform it. We inflate the blood pressure cuff on the arm at a point midway between the systolic and diastolic blood pressure. Suppose patient is having systolic blood pressure of 100 and diastolic pressure of 75. So we will inflate the cuff at 85, that is the midway between them, and we keep it for the 5 minutes. Then we will go to the antecubital fossa, and we will count the number of the petechiae that will be seen in the 1 square inch. And if these are more than 20, then this is positive tourniquet test. So dengue virus infection, if we classify considering the patient infected, then 75% will be asymptomatic. There will be no symptom in that. 25% will be have symptomatic in the form of mild fever or undifferentiated febrile illness. Simple fever will have. And the 5% will have a complication in the form of dengue hemorrhagic fever that can be non-shock or shock, and 5% will have dengue hemorrhagic fever. This 5% is very important for us to pick and to manage. This is a guideline given in Urdu about the management of dengue fever at the home, in the form that patient should apply the mosquito repellent, and they should avoid getting bitten by the mosquito. They should increase the fluid intake as well as ORS, and for the fever they should take paracetamol, and 24, and then those should be not more than 6 tablets per 24 hour of 500 mg. And sponging is advised for the fever along, and the things that medicine that should be avoided in dengue fever are the dispirine and NSAIDs, and you have to repeat the CBC to check the platelet count as well as hematocrit, and you have to inform that the danger signs, that if they get danger signs they should come back, and we should avoid that the colored drinks should be avoided, because they can create confusion with the bleeding, because one of the critical sign of the dengue is bleeding. So first, then after a disease period, you get a convalescent phase. First you have active fever period, then you will get a convalescent phase, and then you will recovery. So what are the signs of convalescent phase? These are that patient will get good appetite, will have pruritus, hemodynamic stability, bradycardia. Bradycardia is important sign. Diuresis. It is also important sign of convalescent phase, because the fluid that has been leaked now coming again into blood vessels and being excreted via the urine. Hematocrit will be stabilized, WBC will be rise, the platelet count will be rise. So these all are signs that patient is improving. So management includes oral intake, antihistamine, rest, and discharge. So once patient go into convalescent phase, you will discharge him. For pruritus, you will advise antihistamine. This picture is showing two important signs of convalescent phase. One is the rash, second is the bradycardia. Now, this picture is basically showing that admission criteria, revised dengue admission criteria, and for the dengue patients. So, what is probable case of dengue? This slide is very important. So, probable case of dengue is that patient is having uh, WBC count of less than 4,000, platelet count of less than 1 lakh, or falling trend in platelet count, a drop of more than 20,000 in 24 hours. So first you get the essential criteria, that is fever that should be more than 2 days or less than 10 days, plus the WBC count is less than 4,000 and platelet count is less than 1 lakh, or you see a drop of platelet count within 24-hour period of more than 20,000. So if you get fever plus these lab finding, you will make him a probable case. Now, how will you will say that it is a confirmed case? The confirmed case is that probable case plus any of these, which may be PCR positive, which may be NS1 positive, which may be IgM positive, or there may be fourfold rise in IgG in the sample. So, all suspected, probable, and confirmed patients with any warning sign or platelet count less than 50,000 must be admitted to hospital for careful monitoring. So criteria for monitoring is that if you get a warning sign or if you get a patient with platelet count of less than 50,000, you should admit that patient. So admission criteria is platelet count less than 50,000 or any of the warning sign. So I have discussed with you that admission criteria, the probable case and the confirmed case. And the warning signs are hematocrit that is less than 30% or more than 50%. Low hematocrit means bleed, and more hematocrit means that the leakage of fluid. No clinical improvement or worsening of clinical parameters, persisting vomiting, severe abdominal pain, shortness of breath, lethargy or restlessness, giddiness, pale cold clammy extremities, bleeding epistaxis, gum bleed, and bloody stools, hematemesis, hemoptysis, menorrhagia, hematuria, pulse pressure less than 25 millimeter of mercury, capillary refill time more than 2 seconds, and less or no urine output for the 4 to 6 hours. Patient with uncontrolled and comorbidities may be evaluated for possible admission. So patient if immunocompromised or some other chronic ailment is going on, so you should admit despite not having a warning signs. So these are the warning signs for dengue, and these needs admission. So what is dengue hemorrhagic fever? So dengue fever plus these finding will make a dengue fever as a dengue hemorrhagic fever. These are categorized in two forms. One is the highly suggestive dengue hemorrhagic fever, and other is the confirmed dengue hemorrhagic fever. So whenever you come across a case of dengue, you should think that whether patient is in dengue hemorrhagic fever or not, because dengue hemorrhagic fever patient needs admission and IV fluid therapy. So highly suggestive of dengue hemorrhagic fever points are disproportionate tachycardia, narrowing of pulse pressure less than 20 millimeter of mercury, capillary refill time of more than 2 seconds, tender hepatomegaly, hemoconcentration in the form of hematocrit, rise of hematocrit 20% rise from the baseline are appropriate 20% if potentially lead, are on rise on approaching 20% of patient already on the IV fluids. Then in biochemistry we will get serum albumin less than 3.5 gram per deciliter or 0.5 gram per dl fall during illness, non-fasting serum cholesterol less than 100, so hypocholesterolemia occurs, or 20 milligram per deciliter fall during this illness, and edematous gallbladder wall on ultrasound. So suggestive feature of dengue hemorrhagic fever are clinical examination as well as lab. In lab we will see hypolipolemia, hypocholesterolemia, and the gallbladder wall edema. So these three things. So you will go for albumin, you will go for the cholesterol level, and you will go for the ultrasound abdomen. Clinical examination, you will check his pulse for tachycardia, CRT for prolongation of capillary refill time, blood pressure for narrowing of pulse pressure, and abdominal examination for and hepatomegaly. So these are the features you should look in the dengue patient. So you first examine his pulse, blood pressure, capillary refill time, abdominal examination, and you order the albumin, cholesterol, and also the ultrasound abdomen. So features that confirm the dengue hemorrhagic fever are that patient is having ascites on ultrasound or prorophion on X-ray chest. So these two features confirm that patient is in the dengue hemorrhagic fever. The next stage of dengue fever is the dengue shock syndrome. So in that can be compensated shock, decompensated shock, or profound shock. In profound shock, there is no BP, no pulse. In decompensated shock, feeble pulses and pulse pressure is less than 20 millimeter of mercury. In compensated shock, pulse pressure is more than 20, but it is less than 30. So 20 to 30 millimeter of mercury. So no pulse, no blood pressure, it is profound shock. Compensated shock, pulse pressure more than 20 and up to 30, and the decompensated shock is the pulse pressure less than 20 millimeter of mercury. Compensated for fluid loss in the form of incompensated shock, body compensate for the fluid loss in the form of tachycardia, pulse pressure gets narrower, and prolonged CRT, and fall of urine output less than 0.5 ml per kg per hour. In decompensated shock, however, the pulse pressure narrows further, leading to unrecordable pulse and BP, and urine output also decreases to less than 0.5 ml. So in compensated shock, the body, although gets management in the form of tachycardia and narrowing of pulse pressure, but it is able to keep his urine output. But here the urine output is less than 0.5 ml per kg per hour, and also the supply to myocardium and brain gets compromised. Now, dengue leak fever, the plasma leak during the critical phase is hallmark of dengue hemorrhagic fever or dengue leak fever. That in critical phase that lasts for about a period of 48 hours, the leakage of plasma occurs. So leakage, where leakage occurs? Leakage occurs within the body. So it occurs into third space, that is pleural cavity, peritoneal cavity, interstitial spaces. So this leak is present within the body. So at the end of dengue, when the patient goes into convalescent phase, this leak has to come out into the blood vessels. So if patient is in fluid overload state, he will not bear that and it go into heart failure. So the fluid that should be given should be kept in mind that this fluid is again coming back to the blood vessels and has to be managed. So if you give plenty of fluids and then at the end when this fluid will come again into blood vessels, you will unable to manage that. So this is very important point. Clinical implications, extravascular fluid loss is variable rate that must be matched with for ml to ml, last 48 hours, and resorption of fluid during the convalescent period. So the critical period during which the fluid loss occurs from blood vessel to extracellular fluid is for 48 hours, and this fluid is not going anywhere outside the body. This is within the body, and this fluid gets resorbed in the convalescent period, and this will create problem for you. So you have to be very judicious during giving the fluids. Monitoring parameter during the patient of dengue hemorrhagic fever that you get admitted in your ward are the clinical and the labs. In clinical, pulse rate, blood pressure and pulse pressure, capillary refill time, and urine output are very important. In labs, hematocrit, platelet count, HB, these are very important parameters. The amount of fluid, how much fluid you should give to patient with the dengue hemorrhagic fever. So first thing was that fluid is given not to dengue fever. It is given only the patient with a dengue hemorrhagic fever, which can be in the form of non-shock or shock. Shock can be compensated or decompensated. That how we have already discussed. So dengue hemorrhagic fever patient needs admission and the fluid therapy. We admit patient not only when suppose we had one criteria for admission was less than 50,000 platelet count. That doesn't mean that patient is having dengue hemorrhagic fever. So the dengue hemorrhagic fever criteria, if fulfilled, we will go for the fluid therapy. Dengue hemorrhagic fever patient can be in the form of non-shock or shock. Shock can be compensated or decompensated. So all this fluid management is for the patient of dengue hemorrhagic fever. So amount of fluid will be based on the weight. For adults, if less than 50 kg, use actual weight. If more than 50 kg, then take the 50 kg as maximum weight. In pediatrics, we use current weight or ideal weight, body weight, whichever is lower. These are formulas for calculating the ideal body weight for less than 1 year, 1 to 7 years, more than 7 years, and this formula can be used for calculating the ideal body weight. So actual ideal body weight, whichever is lower, will be used, and maximum cutoff limit for weight even in pediatrics, like if child of 13 years comes, then 50 kg, not more than 50 kg. So fluid quota, how you are calculating the fluid? The fluid is calculated by maintenance fluid plus 5% of the body weight. Maintenance fluid plus 5% of the body weight. This fluid quota is given over the period of 48 hours. During this, if patient has poor intake, you will keep the patient NPO. If patient has a good appetite intake, you will subtract that oral fluid from this quota fluid. So this is the quota fluid. You calculate his maintenance fluid as per his weight plus 5% of body weight. 5% of body weight means that 50 ml per kg. 50 ml per kg. Again, a child of weight 22 kg, how you are calculating the fluids? So maintenance fluid, as you know, that first 10 kg 100 ml per kg, so it becomes 1000. Next 10 kg 50 ml per kg, so it becomes 500. And the first next 2 kg, you know, that 20 ml per kg, so it becomes 40. So total fluid is 1540 mls. So 5% deficit is that I have already told that you will multiply 50 into the weight in kg. So 50 into 22 is the 1100 ml. So total fluid is 2640 mls. So this will be given over the period of 48 hours. Length of the time over 48 hours if patient presents in the beginning of critical phase without shocks. Very important point that if patient comes in dengue hemorrhagic fever, however he is not in shock, so you will give slowly this fluid over the 48 hours. On the contrary, if in the 24 hours for the patient who are coming already in the shock can be compensated or decompensated. In decompensated shock, no pulse, no BP. In compensated shock, the blood pressure is 20 to 30 millimeter of mercury and urine output is adequate. So what are types of fluid that are used? It can be crystallized or the colloids. In colloids, in crystallides, the 0.9% normal saline for adults. For children, it is half dextrose saline. We use 5% dextrose with saline, and less than 6 months, it is half saline with 5% dextrose water. So important is that children less than 6 months, you use N/2 plus 5%. In children more than 6 months, we use normal saline plus 5% dextrose water, and in the adults we use simple normal saline. And colloids that can be used are the dextran 14 saline and 6% starch. Monitoring critical phase is very important. The vital parameters should monitor hourly. So heart rate, blood pressure, pulse pressure, CRT, these should monitor hourly. Fluid balance sheet is assessed 3 hourly, that how much fluid has been intake and how much has been given in the form of urine output or output. And hematocrit is done 6 hourly. Fluid resuscitation or boluses are given in the form of crystallides, that is normal saline, or colloids can be used like dextran 40% in saline and 6% starch. So all the fluids are part of fluid quota that you have calculated for the in the form of maintenance fluid plus 5%. So any fluid like in the form of oral fluid or boluses, that should be a part of that fluid quota, and you will subtract that from them. So indication for colloids, when you will give the colloids in patient with a dengue hemorrhagic fever who you are going the IV fluid therapy. So failure of cholesterol boluses to normalize the pulse blood pressure, development of shock with fluid overload and amount of fluid exceeding maintenance fluid plus 5%, and dose is 10 ml per kg over 1 hour. So the colloids will be given if patient comes with a dengue fever and the shock state. You give boluses of the normal saline, but patient does not respond. First bolus of 20 ml, next bolus of 10 ml, then you will go for the colloid. Second is that you have used up all of your fluid quota, the maintenance fluid plus 5%, and your fluid quota is not remaining, so you will then shift to the colloids, because in colloids with smaller volume you can achieve a bigger result. The dose of colloid of dextran 40% for dextran or hexastarch is 10 ml per kg, and it is given slowly over the period of 1 hour. These colloids remain for longer period of time in the blood vessels, and they maintain the fluid in the blood vessels. So dengue patient can have a refractory shock, that shock will not respond to your fluid therapy. So what you will look in that patient and how you will manage that patient. So for that patient you will check his blood. So patient may need the blood HB transfusion, may be anemic. Patient may be in acidosis, so may need bicarb therapy. Patient may be hypoglycemic and may need glucose. Patient may be hypoglycemic and may need calcium. Patient may be in the myocarditis, adrenal insufficiency, or sepsis. So if patient comes with dengue hemorrhagic fever, you may give him fluid therapy, the dextran, the normal saline, but patient is not responding. So you will check for all these parameters: his bicarb, glucose, calcium, for any evidence of adrenal insufficiency, sepsis, myocarditis, and low HB. These should be checked and managed accordingly. Monitoring during the shock is that 15-minute monitoring of vital organs, hematocrit immediately before and after each fluid bolus, and then at least 2 hours or 4 hours. So if a patient with dengue hemorrhagic fever, if come in shock state and you give him bolus, then monitoring will be 15 minutely. and before hematocrit, immediately before and after each bolus of normal saline should be checked. A drop of hematocrit or rise of hematocrit is very important. If hematocrit is suddenly dropping, then it means the patient is bleeding. If hematocrit is rising, it means the patient the boluses are not working and patient is having leaking. So the very important part of presentation is that I will discuss with the algorithm that how you are going to manage these patients and how you will follow them. So suppose a patient comes with dengue fever and patient is in the shock state and the shock is compensated. I have told you already that compensated shock means that blood pressure is the pulse pressure is between 20 to 30 millimeter. Patient is having tachycardia, restlessness, agitation, but the urine output is also more than 0.5 ml per kg per hour. So pulse pressure is 20 to 30, pulses are palpable, and urine output is more than 0.5 ml per kg per hour along with other signs of shock. So that patient is in the compensated shock. So how are you going to manage compensated shock? In compensated shock, you will give initially the bolus of crystallide, isotonic crystallide in the form of normal saline with dose of 10 ml per kg over the 1 hour. So repeat second bolus of 10 ml per kg if no improvement with the previous bolus. So in first you will see a patient of dengue. You will label patient whether is simple dengue fever or dengue hemorrhagic fever. If patient is dengue hemorrhagic fever, you will label whether the patient is in shock or non-shock state. If it is in non-shock state, no need to give bolus. If it is in shock state, you will decide whether he is in compensated shock or decompensated shock. So in these slides, we will managing the shock state patients, the compensated and decompensated. So first we are discussing here is the compensated shock. So I have already told that compensated shock means that patient is having tachycardia, patient is having cold peripheries, but pulse is present, but blood pressure is 20 to 30 millimeter of mercury, and the urine output is more than 0.5 ml per kg per hour. So in this patient, we will give initially a bolus of normal saline 10 ml per kg over the 1 hour, and after that bolus, if patient is not improved, you will give another bolus of 10 ml per kg per hour. Next is the decompensated shock. A patient comes with decompensated shock, what you will do? Decompensated shock means that patient is having pulse pressure of less than 20 millimeter of mercury, patient has urine output less than 0.5 ml per kg per hour, and patient is pulseless and blood pressure. So in that patient, you will give the bolus of normal saline at the dose of 20 ml per kg per hour, and it will be given as fast as fast. So in compensated shock, we have given the bolus at the 10 ml per kg per hour, and we have given it slowly over the 1 hour. But here we will give the bolus of 20 ml per kg per hour and as fast as we can. So first you have given the bolus, and then you will look whether the patient has improved or not. So after giving bolus, we will check for the criteria for improvement. That is in the form of peripheries are warm, urine output is more than 0.5 ml per kg per hour, and the pulse pressure is more than 25 millimeter of mercury. On these criteria, we discuss label the patient whether patient has improved or boluses or not. So peripheries are warm, urine output more than 0.5 ml per kg per hour, and pulse pressure more than 25 millimeter of mercury. This criteria makes the patient whether has improved or not. So you, after giving boluses, you will check for these parameters: the pulse pressure, the urine output, and the peripheries. Suppose patient after boluses in compensated shock as well as in decompensated shock has improved. So in that cases, what you will do? So you will keep measuring his urine output. You will infuse normal saline at the rate of 1.5 to 10 ml per kg per hour. So the range, if your patient comes decompensated shock, you will start at higher level like 6 or 7 ml per kg per hour, and you will gradually keep it to the lower level with monitoring of vital. If vital remains normal, heart rate, blood pressure, pulse pressure, urine output, so you will come to lower side. And in case of dengue hemorrhagic fever, simple dengue hemorrhagic fever without shock, you will start fluid at the lower rate like 1.5 ml per kg per hour, and depending upon the need, you can increase it or you can maintain at that level. So infuse normal saline at 1.5 to 10 ml per kg per hour, keeping to the minimum infusion rate sufficient to maintain the urine output of the 0.5 ml per kg per hour. So important thing for us is during fluid infusion is that urine output should be maintained. Upon improvement, fluids can be reduced to gradually to 1.5 ml per kg per hour depending upon the clinical parameters: urine output, hematocrit. Monitor hematocrit 4 to 6 hourly and consider stopping of IV fluid at the 48 hours of plasma leakage or earlier according to the clinical judgment. So earlier, if patient is having good urine output so you can gradually stop the fluids. If the patient becomes unstable at any time, act according to hematocrit levels. So first, in dengue hemorrhagic fever, you will start fluid at 1.5 ml. Simple dengue hemorrhagic fever without shock, you will start fluid at 1.5 ml per kg per hour. You will keep monitoring his the urine output and pulse and the blood pressure. If all the things are in the normal range, urine output is more than 0.5 ml per kg per hour, you will keep the fluid at the 1.5 ml per kg per hour. If urine output drops or the pulse pressure narrows or heart rate increases, you can increase the fluid rate, and your aim is to keep the urine output more than 0.5 ml per kg per hour. And as the child goes into recovery phase in the form that urine output is maintained with reduced fluid volume, you will stop the fluids. In dengue shock state, you will start the fluid. The difference between dengue shock from dengue hemorrhagic fever management fluid is that in dengue shock state, you will start fluid at higher volume like 7, 6, and you will then gradually make it down to the level at which the urine output is more than 0.5 ml per kg per hour. Now, suppose a patient comes with a shock state, dengue hemorrhagic fever, a compensated or non-compensated shock. You give him a fluid bolus, as I already discussed, and patient has not improved. So, what you will do in that case? Now, in that case, you will, after giving a bolus, you will repeat the hematocrit. So, if there is a drop of hematocrit of more than 10 points from the baseline, that shows that patient has bleed. So, if patient is dropping hematocrit more than 10 points from the baseline, so you have taken before the bolus CBC, and you will take a CBC after the fluid bolus, and you will check the hematocrit. If a patient comes with shock after bolus, he has not improved, and after doing the hematocrit, repeat hematocrit, if hematocrit drops more than 10 points, then it means the patient has having some occult or overt bleed. So you will transfuse the blood into that patient. You will transfuse blood into that patient. The dose of blood is 5 ml per kg of the packed cells, and 10 ml per kg is the whole blood. So you will transfuse blood. In case if the hematocrit is increased or unchanged after fluid bolus, or it is less than 10 points reduction of the hematocrit from the baseline, then you will again go for another fluid bolus of normal saline at 10 ml per kg per hour over 1 hour period. So you have go for the another fluid bolus. Then you will recheck for the signs of improvement that we have already discussed. If patient has improved, then you will go to previous slide that I have discussed. If there is no improvement, then again you will check hematocrit. Now again there are two things can happen. If there is decreased hematocrit from the RAS reading, so the again blood will be given. If hematocrit is increased from the last reading, then you will go for the infusion. So decreased hematocrit means that patient is having some bleeding. Hematocrit is low, means HB is low, so some patient has some bleeding, you have to go for blood transfusion. If hematocrit is increasing or not decreasing despite giving fluids, because if you are giving fluid, then the blood should be diluted and hematocrit should drop. If it is not dropping, it means that significant leak is ongoing and your fluid is not been matching with that leak. So after giving a bolus, if still there is a patient is not improving and patient is having hematocrit that is not decreasing or even increasing, then you will go for the colloids in the form of hexastarch or even the dextran 40%. So that should be given. There is a cutoff limit of dextran 40% in normal saline that you can give 3 doses of that in the 24-hour period. So if there is improvement, you will again go to previous slide for the maintenance fluid in the form of that can range from 1.5 ml per kg per hour to 10 ml per kg per hour, and you will monitor. If there is still no improvement even after giving these colloids, then you will again consider the cases to be refractory shock, and you will go for the other parameters like ABGs, CBC, calcium, blood glucose, and ECG. You will check for the acidosis, bleeding, any bleeding evidence of bleed, hypocalcemia, hypoglycemia, and myocarditis. So management of these is that if patient has acidosis, then you will go for the bicarb. Bicarb is given at 1 ml per kg per hour. Maximum amount is 10 ml, and it is diluted in 5 of 10% dextrose water. For bleeding, you will give the packed cells, that is 5 ml per kg of the whole blood, 5 ml per kg of the packed cells or 10 ml per kg of the whole blood. For hypocalcemia, you will give 10% calcium gluconate 1 ml per kg and maximum dose is 10 ml. 1:1 deletion with saline and given under cardiac monitoring. For hypoglycemia, you will give avidextrose 10%, that is dose is 4 ml per kg per kg. For myocarditis, you will start inotropic support. So I will revise this fluid therapy that any patient with a warning sign or platelet count less than 50,000 should be admitted. First thing, then you will look for the signs of dengue hemorrhagic fever. The signs of dengue hemorrhagic fever can be clinical or lab parameter, and then can be suggestive or can be confirmed. The confirmed things for once the patient diagnosed dengue and if patient is having on ultrasound effusion or on X-ray chest of effusion of acute onset, then that patient is confirmed case of dengue hemorrhagic fever. Suggestive feature of dengue hemorrhagic fever comes in the form of clinical examination as well as lab. In clinical examination, the tachycardia, prolonged CRT, narrow pulse pressure, and tender hepatomegaly. While in labs, hypolipinemia, that is less than 3.5 gram per dl, hypocholesterolemia, that is less than 100 milligram per dl, and the on ultrasound pericholecystic edema or gallbladder wall edema. So first you diagnose a patient of dengue, you see a patient who needs admission, you will check whether patient is in state of dengue hemorrhagic fever. The dengue hemorrhagic fever can be non-shock or shock, that can be defined on the basis of following things. These are his pulse pressure. If it is less than it is between 20 to 30, it is compensated shock. If it is less than 20, it is the decompensated shock, and if it is more than 30, then it is a dengue hemorrhagic fever without shock. The other parameters of shock are that patient will have cold clammy skin, prolonged CRT, tachycardia, he will be irritable, and he will have leakage urine output that is less than 0.5 ml per kg per hour. So you will go for fluid therapy in patients with dengue hemorrhagic fever, and you will manage them with the fluids. Fluids are calculated for the period of 48 hours, and these are given slowly, monitoring the urine output. Your target is to keep urine output more than 4.5 ml per kg per hour. The important thing here is that the amount of fluid you are infusing the patient at the end of dengue leak phase, that will again come into the blood vessels, and you will have to manage that, and it will be difficult for you to manage that if you over infuse the fluids. Next important thing is that in dengue, only in state of shock, that can be compensated or decompensated shock, you will give the fluid pulses. An important thing is that before the bolus and after bolus, you have to check his hematocrit. Importance is that if the after bolus hematocrit is dropping more than 10 points, it means that patient is having ongoing bleed. So you will transfuse blood. If patient hematocrit is not dropping or even increasing, it means patient is in fluid leak. You will give him pulses. If not responding to pulses, you will give him the colloids. Now, if there are conditions like if patient is having malnutrition, how will you manage dengue along with dengue fever? How will you give him fluids? If you receive a patient, referred patient, and you do not know how much fluid has been given, how will you manage that patient? And in patient with a septic shock as well as with a dengue hemorrhagic fever, how will you manage these patients? So these are the questions for you to search and to upload these things. So this was a brief review of the dengue fever. The importance is the important point here is the fluid management that I wanted to discuss with you. Thank you.